Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, getting more health out of healthcare. Dr. Mai Pham is the founder and leader of the Institute for Exceptional Care. She also chaired a recent report by the National Academy of Medicine to imagine different ways of paying for healthcare to not only provide great care for people who are sick, but also supports to keep people and communities healthy in the first place. Dr. Pham speaks to Dr. Josh Sharfstein about what this new world would look like and how to get there. Let's listen.
Dr. Mai Pham, thank you so much for joining us on Public Health on Call. Could you start by just introducing yourself to our listeners?
Sure, Josh. So happy to be here. I am a physician. I'm a general internist, and I have spent a career doing research in policy. I've also worked in public service at the agency that runs Medicare and Medicaid, and also in private insurance. And now I lead a nonprofit that's committed to making healthcare better for people with intellectual and or developmental disabilities like autism or cerebral palsy or Down syndrome. That's inspired by my second child, Alexander, who's autistic.
Now, we've known each other for a while, and I think of you as a wonderful clinician, a brilliant policy expert, and a committed advocate for change. So I'm really looking forward to this discussion. Now, recently, you served as the chair of an effort by the National Academy of Medicine called Valuing America's Health, Aligning Financing to Reward Better Health and Well-Being. This is a report that starts with some pretty sobering numbers about life expectancy in this country.
Yes, we are in a situation, it's a lot like a lobster in the pot, Josh. We have somehow gotten ourselves to a point where life expectancy in America has plateaued. It's no longer rising after a century of growth. And we now have life expectancy that is well below that of many of our peers in other rich countries. And the worst part of it is for Americans who are in the prime years of their lives, in adulthood and middle age, life expectancy is actually declining.
Now, this report takes that as the starting point and asks, well, what can we do differently in healthcare in order to improve life expectancy and improve health outcomes? How can we pay for healthcare or pay healthcare differently, I should say? Why did you think about the financing as a mechanism to improve public health?
I think because we recognize that, practically speaking, people follow where the money goes. If you pay for something, that is what people will offer up. If you pay for something else, they will change their behavior and they will chase those new goals. And right now, the dollars in healthcare pay for medical services. It pays for hospitalizations. It pays for procedures. It pays for diagnostic testing. It pays for visits to the clinical practice. What it doesn't pay for is actual health and the things that are far more important in driving a person's health than any of those services. All of those services combined really drive only about 10% of how healthy a person will be. The rest of it is really driven by other factors, including things like your environment, the kinds of social supports that you have, the food that's available to you, and how stressful your life is.
So let's take a visit to the primary care doctor. What's the typical way that would be paid?
So typically, when you have a visit to your primary care doc, they file an insurance claim for that visit, and they get paid a pretty modest amount of money for that visit. And because of that, in order to generate enough revenue to sustain their practice, they have to see a lot of visits. And that means that we all experience the 5, 10, at most 15-minute encounter, which doesn't work if you have a lot of complex issues that need solving, or if you just need someone to listen, to understand your concerns and your goals.
So how does this report suggest changing those underlying financial incentives?
There are some very well-known and respected methods that we think would work better. In particular, it's important to get primary care clinicians off that hamster wheel of fast encounters and billing and fast encounters and billing. And instead, what we want to do is to guarantee them a certain amount of money over a certain amount of time and say, you know what? Within this amount of money, you treat each patient how each patient needs to be treated. You have the flexibility to do that without these cookie cutter 15-minute visits. A second thing that we highly recommend is that, frankly, primary care clinicians are not paid enough right now to take on all of the complexity that we are all bringing to their offices. And so we would want primary care payment, the amount that they are receiving, to rise significantly. I would suggest at least 50% more, maybe even double what it is today. And even at that rate, our country would still be spending only a portion of what other rich countries spend on primary care out of the healthcare dollar.
So paying more for primary care, but also giving more flexibility. If one patient just needs a quick email, that's fine. But if another patient needs a half-hour, 45-minute visit, then that's what the patient should get.
Exactly. And that flexibility also allows the primary care clinician that time to coordinate with other peers, providers of other services that their patient might need, like helping to arrange transportation or finding them a peer support group. Those things don't happen magically. They require someone to do the legwork and to make the connections.
Now, some of these new primary care models exist in the United States. What would it take to really get them everywhere?
To be honest, this is a combination of political will and just attention. It's very easy for policymakers and lawmakers to get distracted by sexier things. And it's not that they don't recognize there's a problem, but they punt it down the road. And we are no longer at a point where we can afford to punt this again.
Now, your report also talks about health insurance. What's the typical approach for health insurance in this country?
Sure. So typically, health insurers pay for, again, those very traditional medical services. And what they do is they set your premium amount based on how many of those traditional services they expect you to use. What they don't typically do is to think about what produces health, although a growing number of them are coming to understand that. So it is not standard, for example, for a health plan to pay for transportation for you to get to a gym. It is not typical for a health insurance company to pay for, translation services if you are a non-English speaker, and that is the only way you can get the healthcare that you need or the services that you need. There are a whole range of services that do exist in the world that people need. You and I, we all know the things that we need. My 84-year-old mother could really use a peer support group. And insurance companies don't typically pay for that. But if they did, they would find that it would grossly reduce the risk of someone needing to be hospitalized or dying. And that would, in the end, save them money.
In the report, you are kind of advocating for a different conception of insurance.
Yes, we would like to think of it as truly a health insurance company as opposed to a medical insurance company. And that is where we would like things to go, with more of an expectation that those extra types of services would be covered.
Would that require perhaps new laws to be passed to get that to actually happen?
I think, unfortunately, it would. Here's where there are a lot of technicalities that we won't have time to get into. But the government holds insurance companies responsible for spending a certain amount of every dollar that you pay to them on these services. If the definition of those services could be expanded to include what we think would actually promote health rather than just medical care, that would help us get closer to goal.
So there were regulations in the past to make sure that health insurance companies weren't keeping so much for themselves. They had to spend it on medical services in a way that's creating a little bit of an obstacle unless you change the definition of what services could count.
Yes, exactly. And maybe we could go even further and say, what is the mix of services that is right?
Talk to me about hospitals. What's the typical approach to hospitals' engagement in their communities?
Hospitals tend to deploy a range of different strategies for being in their community. The most committed ones will have trustees on their board who are from the community. They will have a way of regularly being in touch with community members and with patients who actually use their facilities to get input and feedback in how they design things. And then they have what are called community benefit dollars. So under the tax code, they are required as nonprofit hospitals to spend a certain amount of their money on activities that would benefit their community. But there isn't a lot of tightness around how we regulate and set expectations for those community benefit dollars. And we think that there is an opportunity to be a little bit more prescriptive and to steer those dollars toward activities that really do promote health, as opposed to, say, just offering discounts for community members on medical services. That's a very typical way to spend community benefit dollars. Alternatively, you could invest in a grocery store in a neighborhood that is a food desert currently, and that would actually promote health.
What other ideas do you have for hospitals in terms of making a difference for health?
I think hospitals sometimes function like islands unto themselves. They don't have oftentimes a proactive plan for forming relationships with other groups in the community who could really support their patient population. I'm thinking about social service agencies and faith-based organizations and youth organizations. Those relationships, that is really the safety net that patients fall into when they leave a hospital. And it is also the network that can help keep them out of a hospital. Now, we should all recognize that hospitals are paid when people get admitted to them. So they're not thrilled about the idea of keeping people out. But again, that goes back to whether we can find ways to restructure the incentives that they face so that they are rewarded more for keeping people out of the hospital. Medicare does some of that now. Medicare punishes hospitals if people get discharged and then readmitted too quickly. And so hospitals are starting to learn and develop those skills, but they need to do that much more intensely.
So between our discussion of primary care doctors and paying them differently, health insurance companies expecting them to pay for different kinds of things, and hospitals, you got a lot of details in this report, but there's also kind of a bigger picture, and it's rethinking a little bit the role of the healthcare system.
That's exactly right. I think that the through line here is that healthcare is so in love with its tools and its gadgets and the sophisticated therapies that it can offer. But it forgets that what people want is health on the other end. All those things are supposed to be in service to their health. If healthcare could just step back and take in a much broader perspective about what generates health, and then feel responsible for building those working relationships, for helping people get the resources that they need to stay healthy and be healthy, then it will really be doing its job. Right now, it's a healthcare industry, and we'd like it to be a health industry.
And the financing really matters to get there.
And the financing so matters because it is the tail that wags the dog. We get the exact system that we pay for. And so we need to redesign the payments to reflect what it is that we want.
Dr. Mai Pham, thank you so much for joining me on Public Health on Call.
Thanks so much, Josh.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.